All right. Welcome back to Neil Ratner Rock Doc's Reading Room, where I'm serializing my book, Rock Doc. All right, where did we leave off? I'm finishing up my anesthesia residency at Beth Israel Hospital. Don't want to be a normal anesthesiologist in a group having to take call and deal with all that stuff, but I do have an idea. All right, so let's see what that idea is and where it takes me. Okay. So, by now, it was May of 1985. My residency finished at the end of June, and I needed a plan. The residents graduating with me were split between pursuing specialty anesthesia residencies and going right into private practice in a hospital-based anesthesia group. I wasn't particularly interested in either option. I did have an idea, though. There were a couple of anesthesia residents moonlighting part-time in the offices of a few plastic surgeons. I wondered if full-time office-based work was a viable career option. As far as I knew, no one was doing that in New York. My colleagues weren't keen on making a living outside the hospital. It mostly involved giving a combination of IV drugs to relax the patients and block the pain of surgery, which is called conscious sedation. This type of anesthesia was low-tech science and lots of intuition, and it was just what I liked about the specialty. The sixth sense of knowing how much of what drug to give at exactly the right time. If you remember, during my residency, I had actually concentrated on those small cases when other residents didn't. I had also done my little project on using music in the OR, so I was now developing a little plan of could I actually go into these plastic surgery offices, set up a safe and effective operating room and recovery room, and actually give good anesthesia so patients basically would be in and out within a couple of hours. All right. That was the plan. For surgeons and patients alike, office operations offered distinct advantages. Patients generally didn't like going to the hospital, especially for cosmetic surgery. The fewer staff they saw and the more privacy they had, the better. For surgeons, the multiple advantages of office-based surgery included the ability to build a strong, trusting relationship with the anesthesiologist. This happened less often in the hospital, where each day the surgeon was assigned someone different. In an office setting, surgeons would also be able to use their own nursing staff, a distinct advantage over the alternative. And finally, they could schedule operations at their convenience. Hospitals often had cosmetic surgeons working in the afternoon, an inconvenient time for both the surgeon and the patient. I weighed potential problems. The monitors available at the time tended to be bulky and geared towards hospital use, and many of the anesthetic drugs were long-acting depressants with multiple side effects. Okay for general anesthesia, but not really effective for short office cases. Another problem was the lack of backup. Hospital ORs were filled with doctors and nurses of all types. When something went wrong, within seconds, professionals were on the scene. Not so in offices. That was less of a problem in my case, because as a second-year surgical resident, I had worked in the emergency room of Queens General Hospital, a level 3 trauma center, to gain experience. I was the first doctor a potential surgical patient saw. If the problem was simple, like needing sutures, I handled the case. My main job, however, was to evaluate and help stabilize patients needing surgery. I worked mostly on weekends when the ER was like an intense knife and gun wound repair shop. At times, I thought the borough of Queens was at war. Tough as that was, the most difficult cases were the auto accident victims, who often arrived with multiple life-threatening injuries. I learned to stay cool and make quick, intelligent decisions in the face of real emergencies. So, I was very industrious during my years as a resident. Obviously, don't make very much money as a resident, and I wanted to make money, so I would moonlight on the side when I could. And after your first year of surgical residency, they actually let you work in the emergency room as the surgical attending, so to speak. So any surgical type cases that come into the emergency room, as I said, you're the first guy to see them. And I really liked it. I mean, I liked the drama and the trauma. and at times I thought very seriously about the possibility of going into emergency medicine. I mostly did it on days off. And as I told you, during that surgical residency, there weren't that many days off, but it was on an occasional weekend. Holidays, I remember I worked a couple of Thanksgivings, and I worked on Halloween night, which was unbelievable. It happened on a weekend, and it was like unbelievable, as you can imagine. But it was a great experience, and it came really in handy years later when I started to go to Africa, and I decided to create clinics in Africa. It gave me that extra level of experience. I'll tell you another funny story, though, about surgical residency and making money. So, as I said, I was an industrious guy, and even though I was working more hours than not on a few of those hours off, I did look for extra work. Now, there were these urologists that were doing, when men are impotent, like from diabetes or other types of disease processes, there were penile implants that could be put in. And they're very interesting because they would be like a little valve in the scrotum, and you hit the valve and the penis would get hard and fill up and whatever. At any rate, in order for insurance to cover these procedures, you had to prove that the patient was impotent. And the way that they did that is at night, before a patient went to sleep. In other words, what they did is they bought a little house, right, which had a couple of bedrooms and a living room and a kitchen, just a little tiny house, not far from the hospital. And then they would have their patients sleep there at night. Their patients who were complaining of impotence would sleep there at night. And being an industrious guy, I was friends with these guys, and when they set it up, they needed somebody to hook the patient up to the machine, turn on the porno film, sleep in the other room, and then unhook the patient in the morning, and then bring the recording of the machine. What it was is you had these strain gauges that you put on the penis, on the top and bottom of the penis. Then you showed the patient a porno flick before they went to sleep. And what's normal is that usually early in the morning, there would be some activity. If somebody was not impotent, there would be activity, and you would see it on the strain gauges. If they were impotent, nothing would happen. Insurance companies would pay, and they could have the procedure. But it was great because they'd pay $100 cash, to sleep there at night. I wouldn't do it all the time, but every other resident, wanted the gig. So it was easy for me to find people to cover. And it was very funny because a couple of times, I had my wife, Leanne, come and sleep with me in the other room. Of course, the patient knew nothing about it, but it was kind of a trip. Whatever. So I made some money that way. I made money working in the emergency room. But that was all during my surgical residency. During my anesthesia residency, as I told you, I was trying to become the rock doc, which never happened. And I'll tell you more about that later. There's actually a chapter in the book called The Rock Doc where I'll go into that in detail. All right. So now I have this idea. Maybe I could work with plastic surgeons. Maybe I could set up my own business, go into their offices, set up a safe operating room, and do my thing. Okay. So next step. Who am I going to go to? Which plastic surgeon? All right. Okay, so I decided to approach a cosmetic surgeon about my idea of full-time work in an office OR. But who? A small paragraph in the New York Post jumped out at me. Michael Jackson was seen yesterday leaving the office of his favorite New York plastic surgeon, Dr. Edgar Somers. It is believed Michael was receiving treatment for the scalp burns he suffered during the filming of a Pepsi commercial a few years ago. Now, what caught my eye was both Michael Jackson's name and the mention of Dr. Edgar Somers. I knew him sort of. I had never been assigned to one of his cases, but I had seen him in the doctor's lounge. Like most of the other cosmetic surgeons, Somers was well-groomed, well-dressed, and projected an attitude of confidence. Word among the residents was that he was a good guy, pleasant to work with. All right, I had my guy. Now, you have to understand, and I'm sure most of you know, I ended up working with Michael Jackson years later. But Michael only attracted me at that time because I knew whatever plastic surgeon Michael was going to, that's probably the guy who has the right kind of office for me to go in, because he'll have the right kind of patients. He probably is pretty well healed, so I could get the safe kind of operating room and recovery room I wanted. And yeah, okay, I had my idea. I had my surgeon, and now it was time to do it. And next time, I'll go into what I did and how I convinced him and what happened from there. There was one more piece to this puzzle, and I'll talk about that next week. I want to catch you up. You remember a couple of weeks ago, I told you about Leo Zeff, MDMA, psychedelic psychotherapy. This is now a number of years later, and I've progressed. And that had a lot to do with my idea of office anesthesiology, but you'll have to wait for next week for that. All right, now, come on. All right, so that's it for today. I hope you enjoyed it. Join me again next week. You heard what I'm going to talk about, and hopefully you'll enjoy that. And you know where to find me: iHeartRadio, Spotify, and my posts all week long. All right, that's it for today. Have a great rest of the week. I'll see you next week. And always remember, keep on rocking. Bye.